All right, good morning, everyone. Welcome to the Department of Pediatrics Grand Rounds. My name is Dr. Kiran Masood, and I'm honored to introduce today's speaker in Dr. DeVasquer's absence. This session marks a significant milestone. It's our first in-person Grand Rounds since 2020, and the first held in collaboration with the Global Health Program at DGSOM. Additionally, today is Thank a Resident Day, observed annually on the last Friday of February. This special day, led by the Gold Humanism Honor Society, recognizes the dedication and invaluable contributions of resident physicians and fellows worldwide. As we join in the celebration, we extend our gratitude to 150,000 residents and fellows who provide compassionate care every day. We see you and we appreciate you. It is now my pleasure to introduce our esteemed speaker, Dr. Grace Chan. Dr. Chan is an associate professor of pediatrics at the Children's Hospital of Philadelphia. She is a physician scientist with specialized expertise in epidemiology and public health, and a core faculty member at Clinical Futures, a research institute center of emphasis at CHUP. Dr. Chan completed her pediatric residency training at Boston Children's Hospital, Boston Medical Center, and went on to pursue 2 postdoctoral fellowships, one in international health at Johns Hopkins Bloomberg School of Public Health, and another in child health at the International Center for Diarrheal Disease Research in Bangladesh. Dr. Chan's research focuses on designing, evaluating, and implementing interventions to reduce mortality and improve the health of mothers, newborns, and children globally. She has partnered with community-based organizations, government agencies, and the World Health Organization to discover and deliver cost-effective interventions for vulnerable populations. She is currently the PI for several large Gates-funded studies that focus on estimating the morbidity and mortality of women and young children in regions in the world like Ethiopia, where reliable data is limited. Dr. Chan has authored 57 peer-reviewed publications and received over $30 million in competitive research grants, including $14 million as a principal investigator. The title of our talk today is Improving Child Survival and Well-Being in Vulnerable Populations, Evidence-Based and Community-Driven Solutions. Welcome, Dr. Chan.
Hi, everybody. Good morning. And it's a real pleasure to be here today. I'm just really grateful for this opportunity to be together during some challenging times. A big thank you to SAD for inviting me here with the Global Health Program. And thanks, Karen, for that beautiful introduction. And congrats to the residents. We appreciate you more than you might even know and anticipate. But I'm absolutely delighted to be here today to present my research to improve child health in vulnerable populations. I think right now at the moment, these are turbulent times in our field, and our mission for social justice is more important now than ever. So this is an overview of my talk. I'm going to present the background describing the magnitude of the problem my team is focusing on solving. Then I'll present our research program and highlight study findings that may be of interest to you. And then I'll end with a future vision, which may be changing, I guess, as we see what happens in the next couple days to months. So in terms of the background, in 2005, Lancet published a paper where children are dying around the world, and each dot represents 5,000 deaths. And I thought about how most deaths were concentrated in certain parts of the world, and I was motivated to go to where there was the highest number of deaths. So my initial work was in India and then in Bangladesh, where I did my PhD research and postdoc. And currently I'm working in Ethiopia, which is the second most populous country in Africa. It is one of 5 countries that contributes to more than half of child deaths less than 5 years of age. So this prompted additional questions about how many children are dying and what are they dying from. So these are some more recent data. In 2019, there were 5.3 million deaths among children younger than 5 years. and that had decreased from the 10 million in 2005. So there's been tremendous progress in the last couple decades. Most data are modeled from cross-sectional surveys, and this will be important in my next slides. To give you more background, of the 5.3 million deaths, 2.4 were among newborns, about 28 days, less than 28 days of life, and about 2.6 million were from infectious causes. These are largely vaccine preventable deaths, such as lower respiratory infections and measles. 240,000 were from preterm birth complications. And these numbers were really what laid the foundation for my work in this area and the founding of my research program, HASET, which means happiness in Amharic. Our vision is to end all preventable deaths globally, where every child has the opportunity to survive and reach their full potential. Our program is guided by 5 principles. We look to be data-driven, user-centered, integrated, outcome-focused, and partnership-based. And we try to focus on the continuum of care for pregnant women and their children. So starting from pregnancy identification as early as possible through antenatal care visits, health facility-based deliveries, essential care for every baby, child health, and then at the center is this mother and child dyad. And as I mentioned earlier, most estimates of child morbidity and mortality are generated from models from cross-sectional studies. And there was questions around the accuracy of modeled data, as well as context-specific settings. So in 2018, we established a field site in Ethiopia that was founded to count every pregnancy, every birth, every death, to estimate accurate measures of morbidity and mortality in Ethiopia among pregnant women, postpartum women, and children less than 2, with near complete denominators, which allows us to create estimates that we thought could be more accurate and helpful to the Ministry of Health when they're targeting and developing their strategies for resource allocation. The site also includes 8 health facilities, 3 hospitals, and 5 health centers. There are health services that are provided free of charge by the Ministry of Health to all pregnant women and children less than 5. And the site includes 20,000 households, all of which are geocoded, a population of about 90,000 people, and it fluctuates given some of the migration patterns. And it also has a large IDP population given some of the current events in Ethiopia. It's in Amhara region in the North Shoa zone, and there are approximately about 2,000 births per year. So we also have a nested pregnancy and birth cohort. So to bring you to Ethiopia, this is one of the villages in our site. We work with 16 kabeles, and this is the most remote village where there's no road access, and the nearest health center is a 12-hour walk. This is a picture I actually took. I've been to every village except for this one, and I was on my way here when I got to where I took this picture, and there was a cliff to go down in order to get to the village. And my team was, telling me, come on, Dr. Grace, let's go. And I thought I could hike, and I looked down and I was like, I would probably roll down this whole thing. And then the longer route would be about a 12-hour walk. And so this photo reminds me to visit, and I promised I'd return when I had some more time. But this illustrates that to access healthcare, pregnant women or sick members of this community would need to walk about 12 hours to get to that access healthcare. So our site is it's in the highlands and the lowlands. So we picked 2 districts in the North Shoa zone. This here is the highlands, where it is colder and there's a higher prevalence of respiratory illnesses. If we go to the other district, which is in the lowlands, it tends to be warmer, and there's a higher prevalence of febrile illnesses and acute diarrheal infections. And so we wanted to diversify the types of morbidity that we would see. And so we had selected these 2 districts after a rapid assessment of about 5 different areas around Ethiopia. So there's 2 components of this field site. There's a health and demographic surveillance system. And here you'll see an illustration of what we call an HDSS. We start with an initial census, And it's a dynamic cohort that's updated every 3 months with house-to-house cross-sectional surveys where data on basic health demographics, so births, deaths, marriages, pregnancy status, migration status are collected. And an individual can enter the cohort through birth and in migration and exit through death and out migration. Nested within this cohort is a pregnancy and birth cohort that I'll talk about in a moment. This is just an illustration of the types of forms that we would collect in each of the rounds. There's about 8 forms, which could be completed pretty quickly, depending on any changes that have occurred in the household. And so this is a schematic of the pregnancy and birth cohort, and you'll see that there's many more visits. Women are followed through pregnancy and their newborns from birth to the first 2 years of life. And there's active surveillance through scheduled follow-up visits. And you'll see that the visits are more frequent as we get closer to delivery, because we wanted to really capture those events where we don't have much information about, what's happening at time of birth or during labor, and to be able to better estimate outcomes. And then we have passive surveillance, which happens at health facilities when women or their children will present for care, either an antenatal care visit, a postpartum visit, or a sick visit. And this allowed us to estimate outcomes like coverage of prenatal and postnatal care. This is a table of the types of data that we collect on symptoms and signs of morbidity. So we look for the signs and symptoms of morbidity, anthropometrics, laboratory data, sociodemographic data, and mortality for both the moms and the children. And then specifically, because this site was also developed to focus on maternal and child outcomes, we look at, among the pregnant women, postpartum women, and children, any clinical diagnoses of illnesses and illness severity at each level of the health system. So at home, community levels, and at the health facilities. And we're particularly interested in adverse birth outcomes like low birth weight, preterm birth, small for gestational age, and then stillbirth, newborn mortality, child mortality, and maternal mortality. And this was largely developed with the Ministry of Health, given their priorities for what data they wanted to have access to. So this is a population pyramid of the health and demographic surveillance system by age and sex. So this was data from 2019 that is now superimposed on a population pyramid from 2007, the national census. And you'll already see that Ethiopia is undergoing this demographic transition where on the bottom, which is children less than 5 or children less than 10, that pyramid is starting to shrink. So this illustrates that at that point, the mid population in 2019 was 82,000 people, 19,000 houses, 12% of the population were less than 5, and the gender ratio was 1.02 with slightly more males than females. So next, I'm going to highlight some of the research findings that may be of interest that leverages initially this field site and then some of the other studies that I've been working on. So the Burhan field site generated evidence on mortality and also vulnerable newborns. And this is a paper where we estimated for the first time in this part of the world, the incidence of stillbirths, because it's so hard to measure stillbirths unless you had strong pregnancy surveillance and could identify every woman who's pregnant as early as possible. And we also estimated newborn mortality and vulnerable live births in Amhara, Ethiopia. So just to present some of the data that may be of interest, we found a high proportion of adverse birth outcomes. So the preterm birth rate was about 15%, and this is with ultrasound gestational age dating. So we introduced ultrasounds to the health facilities, and were median age of the women when they were scanned were about 22 weeks. To put this in context, the US CDC data showed 10% preterm births in the United States in 2020. The low birth weight rate is 9.4%, just slightly higher than the US rate at 8.2%. And stillbirth rate was 2.3%, which is about 4 times higher than the US population of 0.6%. So this raises a lot of questions around, what are the etiologies of stillbirths, and are we actually capturing the stillbirth rate in other settings, because it may be higher than we anticipate. And then this figure here illustrates the different newborn phenotypes by gestational age and birth weight to try to create a risk identification for more vulnerable newborns. And you'll see that the vulnerable phenotypes are at higher risk for mortality. So mortality is lowest among those babies who are appropriate for gestational age and term babies, that's in the green quadrant. And that's about, the mortality rate for those babies is about 1.5%. Mortality increases to 4.7% among the 40% of the babies who have at least one or more vulnerable phenotypes, and that's the other three quadrants. So 60% of the babies are appropriate for gestational age or term, and 40% have at least one of these vulnerable phenotypes, and that mortality rate is 4.7%. And as you would expect, the mortality is highest in the quadrant that has both preterm births and low birth weight babies, where that mortality is at 24%. So this highlights the importance of being able to identify babies born in high-risk groups to target interventions and allow stakeholders to advocate for resources that are needed for interventions in these high-risk populations. At the moment, I mean, when we were doing the study, about 3% of the births in Ethiopia are weighed. And so the ability to do some more risk prediction is useful if we could do something basic like weighing all the babies who are born. We also found an increased proportion of deaths among male babies compared to female babies. And so this had compelled Getachew Kasa, who is one of our postdoctoral fellows in Ethiopia, to collaborate with Emily Thompson, who was a master's student with me in Boston, to conduct a survival analysis among children less than 2 by sex. And this analysis showed that about 67% of the newborn deaths and 64% of deaths by age 2 were among male babies. And they had a hazard ratio twice as high as females in the first 28 days of life. And after the first 28 days of life, the mortality rates were equal between the two groups. And I think this raises questions about why. And I think we see this in the United States, and we see this in many parts of the world where the male babies tend to be more vulnerable than the female babies. And sometimes that switches later in life, perhaps due to social factors. But that's another study if anybody here is interested in that, because I think there's so much we don't know about the biological mechanisms for what could be causing that. We also noticed, just being in the field, that the kids who we thought looked like they were maybe 4 or 5 were actually like 7 or 8 years old. So we saw this visually, we could appreciate this high incidence of stunting. So one of my postdocs co-led with our team's research manager. We like to pair someone from Ethiopia who's been working on our study in the field site with a student or investigator that may be trained in epidemiology. And so together they kind of co-lead these studies. So this was just a beautiful example of a postdoc with our research manager in Ethiopia working on a study that was estimating the incidence of stunting and found that stunting had increased over time. And it's almost like as the baby is able to breastfeed, and at 6 months when they wean, we start to see increased incidence of stunting. And it's highest between the ages of 12 and 24 months, where stunting was at 51% compared to WHO growth standards. Capacity building was something that was of interest to the Ministry of Health. And so we leveraged this field site as a training site for fellows in Ethiopia. And last year we'd graduated our first cohort of 9 fellows. And these fellows developed 15 manuscripts and 11 policy briefs. So here's our graduation ceremony with the Minister of Health and the Director General of the Ethiopian Public Health Institute. And we had a poster presentation in the tent outside by the fellows. What we thought was, and this fellowship was really co-developed with our colleagues at the ministry and academic institutions in Ethiopia. And one of the gaps we tried to address in our work was this gap in translation of evidence to policymaking. And so our approach was to prioritize and co-design studies both with researchers and with the policymakers. So one postdoctoral fellow was paired with a case team lead at the Ministry of Health from the very beginning, so they could decide on what research question to answer. Was it going to be relevant to policymaking? Could the ministry adapt this into programs or policies based on the results? And that way we were able to select research questions that hopefully would be relevant to the local policies. And then, so the postdoc fellow, they would work together, and the postdoc fellow was really leading the analytical piece of kind of the research and the the Ministry of Health case team lead was working on the policy brief component. We also had our fellows as part of the ministry's Research Advisory Council, so they could really be part of this policymaking process. The Minister of Health was very supportive and advocated for the importance of research for sustainable, cost-effective interventions and resources. And so she quoted at this graduation ceremony this beautiful quote about the importance of research, and then proceeded to ask us to train a couple thousand new fellows. So it's a very ambitious government system. So the next study I wanted to talk about is about newborn infection. This may be of interest to particularly people who are in infectious disease physicians or neonatologists. And so we saw from earlier slides that newborn infections are one of the top 3 causes of mortality among newborns. So I co-designed and served as an epi lead. This is a carry-on from some of my PhD dissertation work. And so this was a large multi-country study looking to understand the etiologies of newborn sepsis and antimicrobial resistance in 7 low middle income country settings in Africa and South Asia. We enrolled 36,000 newborns, of which 2,500, about 7% were diagnosed with laboratory confirmed sepsis. So we, in most areas, there is limited microbiology capacity. So we were lucky to have some resources to build microbiology capacity at these particular settings, so we could better identify the etiologies of sepsis and antimicrobial resistant patterns. So I think this is the first time where we have a cohort study where we learned that about 7% had blood culture confirmed sepsis. And Klebsiella was the main organism that was isolated, followed by Serratia and E. coli. And we used whole genome sequencing to identify antimicrobial resistant genes. And we were able to find that in a lot of the pathogens we isolated. So we saw about 90% of the isolates resistant to ampicillin and gentamicin, which is your first line antibiotic by WHO for newborn sepsis. This map shows the 12 study sites, the number of cases contributed to the study by each site, and the proportion of early onset sepsis, which is in the light green, compared to the late onset sepsis in the dark green circle as part of the pie chart. And this was important because we were curious how these babies were getting sick, and is the mechanism for developing sepsis different if you're an early onset sepsis case versus a late onset sepsis case. Also, probably not surprising to many of you here, the case fatality was high among those babies who had confirmed laboratory sepsis. So that's the orange line, the orange bar here, and that was at 20%. And this is similar in both Asia and Africa, which raises a lot of, I think, health service questions about the time to diagnosis, the treatment that's available, if are these, among the bacterial infections, if there's resistance to Ampangent, are we missing an opportunity to really treat the infection with the appropriate antibiotic? There were also differences in the gram-negative species that were recovered from the blood cultures at each site. In Ethiopia, there was a predominance of Klebsiella, which was similar in Pakistan, and Bangladesh had a significant portion of Serratia cases. And this just illustrates the importance of context-specific data because each environment may have different etiologies of sepsis and different antimicrobial resistant patterns. So this work, what's I think exciting about this work is it's contributed to upstream development of ideas like maternal vaccinations for organisms like Klebsiella, that could be given to a pregnant woman to reduce the prevalence of newborn sepsis, and then also consequently the antimicrobial resistance. At the policy level, WHO is revisiting its recommendations for first-line antibiotics for newborn sepsis, but the question is, what can you really go to? In Ethiopia, there was a discussion about using amikacin as the next line, and I think this is probably, there's more discussions to be had about the pros and cons of that. And then the other policy changes that have happened is more attention to infection prevention control programs in facilities where we did see a couple outbreaks in the NICUs where we were working, which prompted the leadership at the facility to close the NICU, move the babies, and really try to clean and sanitize the environment. This is another paper that was led by a PhD student, Rebecca Milton, where we looked at the incidence and associations with newborn sepsis and all-cause mortality. And here, it's another Kaplan-Meier curve, where we compared the magnitude and time to mortality among newborns with either clinical or laboratory confirmed sepsis. So the clinical sepsis is in red and the lab confirmed sepsis is in blue. And you'll see that time is on the x-axis, survival is on the y-axis, and the lab confirmed sepsis cases had increased mortality. And 66% of the newborns had died in the first 7 days of life, 88% in the first 28 days of life. So this work has also led to the investment of microbiology capacity in low middle income country settings, ideally to be able to better diagnose babies who may have labs confirmed sepsis and to better target interventions to that particular population. And then also it's led us to explore potential interventions to prevent newborn sepsis, such as the use of probiotics among infants. And I'll talk a little bit more about that in a later slide. So my work in surveillance and large observational cohort studies have generated preliminary evidence to design and test interventions to improve outcomes. The last research study I'd like to highlight is on the scallop of evidence-based interventions. So we had heard that complications of preterm birth are one of the main causes of mortality among children less than 5. And globally, we see that there is about 15 million babies born each year of preterm, which is defined as less than 37 weeks. The map on the left shows the absolute number of preterm births by country, and similarly to the mortality map, it's usually concentrated in the countries that have the greatest absolute number of people. And preterm birth is a unique global problem because it affects all countries. So about 1 in 10 are born preterm, kind of no matter what part of the world you're in. But while the risk of preterm birth is high for both low and middle income country settings, there's a difference in the survival if you're born preterm based on where you're born. So of the 15 million babies who are born preterm a year, about 1.1 million die, and most of them are dying in the low income country settings. And so you'll see this bar graph where there's regional variation of mortality rates among preterm babies. The high income country settings are on the left, and then the countries in sub-Saharan Africa are on the right. And you'll see that it's up to, in 2010, a total of like 12 deaths per 1,000 live births among the preterm babies. So WHO had produced recommendations for preterm babies, including kangaroo mother care, continuous positive airway pressure for babies with respiratory distress syndrome, surfactant for the preterm babies, oxygen or room air during ventilation, and then increasing the oxygen concentration if your initial intervention is not working. But many of the settings that we work in probably don't have access to these resources like CPAP devices, surfactant, and oxygen. When I first started working in Ethiopia in 2015, the health facilities, none of them had oxygen, even the tertiary care centers. So more recently, the tertiary care centers have introduced CPAP, and there's been a couple oxygen tanks that may be shared among the newborns in the NICU. So the conclusion was like, well, what about kangaroo mother care? It seems easy to do and it's easily accessible because there's a mom or there's a caregiver who's present. It is a behavioral change intervention that seems to be, I find them a bit more challenging to implement and to scale. But due to the resources that are available, it seemed like it would be the most ideal option. So what is kangaroo mother care? There are several definitions, and the most widely adopted definition by WHO includes these 4 components. So it's early continuous skin-to-skin contact between the mom and the baby, exclusive breastfeeding, early discharge from the hospital after you've initiated KMC with continuation at home, so the baby might not get it. They're at a lower risk to get an infection in a health facility, and then adequate support and follow-up. And Ellen Boundy, who's a PhD student with me, led a meta-analysis and review of KMC literature, and she found that KMC reduced mortality among low birth weight babies by 36%. And in addition to the reduction in mortality, there were other benefits, like 33% reduction in newborn infections, a 66% reduction in hypothermia, and a 50% increase in exclusive breastfeeding. So we have strong evidence from our review and from prior Cochrane reviews that KMC reduces mortality. However, the coverage of KMC, which is defined as the percent receiving an intervention among those who are eligible, is still low. So this graph is, I think this is what I have in my office and I look at almost every day, is that one of the biggest challenges to improving health outcomes is how do we deliver known evidence-based interventions to achieve high coverage? So this graph shows the years since introduction of the intervention on the x-axis and then percent coverage on the y-axis. So here you'll see interventions like antiretroviral drugs, vaccines, oral rehydration solution, and they took about 15, 20, 25 years from conception to reach 50% coverage. So a question is, why does it take so long to actually scale interventions that we know work? I mean, I think we're dealing with a vaccine coverage issue at the moment. So there's, it's, I think, quite complex with the many different factors that play in these numbers. And then you'll see KMC. So KMC is this flat line that's purple on the bottom, and it's been about 5% in the last 40 years. And, when you look at this data, you're kind of like, well, first of all, it takes a long time to scale interventions that work. And then why is KMC, which has evidence to show it reduces mortality by 25%, 36%, why is the coverage so low? So attention was brought to this issue in 2012 when the Born Too Soon report came out by the March of Dimes, Save the Children and WHO. And kind of prompted by this report, the Gates Foundation Saving Newborn Lives gathered a group of newborn experts in Istanbul to discuss, how do we accelerate the implementation of KMC? And so this led to the formation of the Kangaroo Mother Care Acceleration Partnership. And the partnership identified a key research priority. How can we increase the coverage of KMC? So I was a member of this meeting in Istanbul. I never thought I'd become an expert in KMC, but sometimes I guess if you're in the right place at the right time, then you develop expertise in a certain area. And so funded by the WHO, I supported the development and a multi-site study trying to scale KMC in 7 different sites in 2 countries. And each site had a population of about 1 to 1.5 million because we were targeting the small babies. So I think I left out the, so in all the sites, we were able to receive 80% coverage after 3 models. So we developed, we used an approach called an adaptive intervention design, where we started with 1 model based on our formative research. And then we implemented the model in a small number of facilities at each of these sites. And we had an evaluation team to assess coverage. And then we had a formative team that looked at what are the barriers to achieving higher coverage and what are the facilitators. And we had an implementation team. So after about 3 months of implementing the first model, we learned what we could do to improve the next model. So we did this iterative design about 3 times until we achieved 80% coverage at the facilities. And then we took that model and we scaled it to the other parts or the other facilities in these areas. And as you would expect, we hit 80% coverage when we were super dedicated at a small number of facilities. And when we scaled it, it was better than 5%. So, but it was down to like 50%, which was still, I think, not as good as 80%, but better than the 5%. So this work led to a national scale up of a package of newborn interventions, including KMC. So the Ethiopian Ministry of Health, based on our data, kind of took on this project with funding from GFF in a population of about 40 million in Ethiopia. And we then, as researchers, became more technical advisors, since implementation at such a large scale really depends on the Regional Health Bureau and the Ministry of Health for sustainability. Our work contributed to the latest WHO guidelines on care for the preterm and low birth weight baby that launched in November of 2022. And I'll just use the last couple of minutes to talk about vision and kind of what future studies could look like if people are interested in collaborating or have access to donors, because we're not sure what's going to happen in the next couple of months. So the first study I wanted to talk about is related to the newborn sepsis research findings and antimicrobial resistance. So the question that came up is, can we prevent newborn sepsis? And so we are starting a trial with WHO in 5 countries for probiotics. So testing the effect of probiotics among breastfed infants on mortality, morbidity, and growth in the first 6 months of life, and a population of vulnerable babies, so those who are preterm and small for gestational age. To our knowledge, this is the first large trial among about 30,000 babies, and each site would be screened to find those small for gestational babies and preterm babies, and we estimate probably about 5,000 in each site. We're proposing 2 trials, one in each of the vulnerable populations. So in the preterm and term SGA baby population, the babies will be individually randomized at 24 to 72 hours of life to either the intervention, which is a formulation of probiotics, or a placebo with daily doses administered for 28 days. The outcomes are going to be assessed every 4 weeks during home-based surveillance for mortality, growth, severe infections, hospitalizations, and underweight. We're in the process. This study has been delayed because it's taken some time to manufacture the probiotics, and also in terms of seeking ethical approval from the different countries, particularly after the US FDA had put a black box warning around the use of probiotics among newborns. So, we also, I think the study hopefully will help us understand if this could potentially be an intervention that would reduce mortality among newborns, given that there's, ampicillin and gentamicin is not super effective, and there's limited other interventions. The platform also provides an opportunity to understand what is the mechanism for how probiotics could work in this population, and are there microbiome related features that may allow a baby to be more likely to benefit from probiotics versus not, and how does this have an effect on the newborn immune system? So stay tuned for potential other nested studies within this trial. Kind of the second area of research is leveraging the work from our morbidity and mortality estimates. We're looking at exposures, like temperature and our air particulates are the exposures on health outcomes. And why this was kind of interest to us is because, like everywhere else in the world, there's been increases in temperature here, as well as and what is the interaction between increased temperature and increased PM 2.5. So this is, what's really exciting about this opportunity is that NASA was planning to launch a new satellite in 2026 called the Maya investigation, which is the first time in NASA history where they're going to link satellite data on temperature and air to health outcomes, and they're working with epidemiologists. So there are 11 primary target areas of the satellite, one of which is Ethiopia. And so this is a 400 square kilometer boundary of the satellite. And you'll see our field site is in the upper right corner. So the field site falls within the boundary of the satellite. And when I spoke with the PI of the Maya investigation, I gave him the coordinates of our field site, and he's like, "Oh, let's try to move the satellite 1 degree, northeast to make sure we capture all the houses in our field site, because it's rare to have this opportunity to have health outcome data and then to have almost real-time exposure data and look at what that association could look like." So this was submitted to NIH, and study section did meet in February, and we have a score, but since it has the words climate and it's in Ethiopia, I think we have to look for some other opportunities. And then lastly is this area around the climate, biodiversity, and health. There's interest in, what are the implications of increasing temperature and high air particulates on health. And, there's comparisons with nature and RCTs, given that nature is constantly refining to improve. And could it be actually better than a clinical trial? So like going to places like here in this picture, this was up in the Amazon, which is one of the most biodiverse parts of the world. Like, are there potential interventions here or models that exist that we could adapt for interventions that have not yet been discovered? So that's another area of interest. And lastly, I think, it's these are kind of some ideas around future directions, looking at developing new evidence-based interventions that are somewhat community-driven. And hopefully in the next couple of years, we'll have some results from these studies. So thank you. I'd like to thank all my partners, donors, and team members, and the moms and the children who contributed to this work. Thanks. I'm happy to take any questions.